Hi and welcome to this movement disorder presentation. On this presentation, I'm going to talk about recent changes in clinical approach to dystonia. Following topics will be discussed: how to diagnose dystonia and recent clinical approach. As you might know, the clinical approach is a stepwise process. It begins with phenomenology of dystonia, including definition, then putting clinical finding into a two-axis clinical feature, finally generating differential diagnosis and arranging specific diagnostic investigations. So what's dystonia? The term comes from dys means bad, plus tonia says posture. Dystonic movement takes two forms, tonic and phasic. Tonic is that bad postures, like spasticity. But it could be phasic, and in this case, look like chorea, tremor, or myoclonus. Dystonia have got other clinical hallmarks. Dystonia is a pattern movement disorder. It means it usually involves the same agonist and antagonist muscles, like tremor or tic. It's also a twisting movement, means it moves around a specific axis, like chorea. Dystonia is not always a fixed posture. It might be tremulous, so likes to tremor. It also related to voluntary movements. Thus, it may not be detected at rest. Sometimes it even occurs only by a specific movement or tasks, then called task-specific dystonia, for example during playing music or writing. Dystonia sometimes overflows to non-dystonic parts. Dystonia of hands to arm or arm to neck. An exciting finding in dystonia is that it might alleviated by simple sensory trick. For example, touching chin diminishes cervical dystonia. This phenomenon is called jest antagonist. Another unusual phenomenon is mirror movement, in which the unaffected or less severely affected body side get dystonic movement during repetitive tasks of the most affected body side. The second step to approach dystonia is getting more information in two axes. There are 4 items in the clinical characteristic and 2 in the etiologic axis. The age of onset has major clinical significance. As the dystonia begins in younger generation, finding an underlying cause is more likely than older age. If dystonia begins in infancy, the primary culprit is inherited metabolic disorder with specific diagnostic implications and grave prognostic consequences. In childhood dystonia, if disease course is progressive, dopa-responsive dystonia, and if disease course is static, cerebral palsy are main causes. The primary dystonia is the most frequent cause of adult-onset dystonia. Dystonia affects any part of the body. It could be focal, means single anatomic segment, like cervical limb dystonia, segmental, when it involves 2 or more adjacent segments, or on one side or hemidystonia. To be called general dystonia, the trunk should be affected. The most focal primary dystonia in adult is cervical dystonia. When the patient head turns to the side, it called torticollis, tilts laterocollis, flexus anterocollis, and to the back retrocollis. Blepharospasm is a focal dystonia involving eyelid muscles and lead to involuntary closure of eyelids. Segmental dystonia over orofacial and mandibular muscles is also known as Meige syndrome. It's one of the most common primary dystonia in adults. In young adults and children, oromandibular dystonia are distinctly unusual. They should raise the concern that it's an early manifestation of what will evolve into combined dystonia syndrome or neurodegenerative disease. Very prominent oromandibular dystonia could be diagnostic in some disorders, such as Lesch-Nyhan disease, glutaric aciduria, neuroacanthosis, and neuronal brain iron accumulation disorders. The picture shows severe orolingual dystonia and self-mutilation in patients with Lesch-Nyhan syndrome. Isolated limb dystonia is not as common as cervical or facial dystonia. Generally speaking, focal limb dystonia in adults, if it occurs in specific actions such as writing or playing instruments, will be task-specific dystonia. Otherwise, one of the Parkinsonian syndrome, such as corticobasal degeneration or CBD, should be thought of. Isolated or very prominent truncal dystonia at any age should raise suspicion of acquired or neurodegenerative disorder, especially tardive dystonia, as you can see in this picture. In adults, truncal dystonia may lead to forward bending. We call it coptochromia, backward bending, opisthotonus, or sideways bending, piezo syndrome. Well, the third characteristic in axis 1 is dystonia's temporal pattern. In the setting of multi-system neurological disease, the temporal sequence of the problem can have diagnostic significance. Degenerative diseases, primarily targeting gray matters, are more likely to give rise to dystonia plus dementia and epilepsy. But degenerative disease, primarily targeting the brain white matters, are more likely to present with spasticity or ataxia. Certain conditions characteristically begins with a particular movement disorder, and other neurological manifestations only occur later. For example, dopa-responsive dystonia usually manifests predominantly as dystonia in childhood, but Parkinsonism becomes increasingly prominent with older age. To differentiate paroxysmal dystonia from action dystonia, few points should be remembered. Action dystonia is always triggered by the same activity or actions, such as task-specific dystonia. In paroxysmal dystonia, the same trigger might or might not induce an attack. In contrast to paroxysmal dystonia, in action dystonia, the same motor activity will predictably produce dystonia. Finally, paroxysmal dystonia typically lasts after triggers has ended, while action or task-specific dystonia is no longer seen when the inducing action is completed. One of the significant changes in terminology and approach to dystonia is dividing it into isolated or combined forms. Isolated dystonia applies when dystonia is the only motor feature, except for tremor. On the other hand, combined dystonia applies when there are dystonia plus other movement disorders, such as dystonia plus myoclonus or dystonia plus Parkinsonism. There are two potential sources of error in detecting isolated or combined dystonias. The first is that misdiagnosis dystonia as another movement disorder. For example, limb dystonic tremor as tremor caused by Parkinson's disease or essential tremor. On the other hand, you might find the tonic posture of dystonia, but its jerky feature making confusion as myoclonus movement. This might lead to mislabeling a syndrome as combined when it's actually an isolated dystonia. Phasic dystonia can mimic many other movement disorders like tremor or tic. Differentiating clinical features are movement disorder in the same part as bad posture are more likely dystonic. Like tremors movement in the dystonic arm is more likely a dystonic tremor than, for example, Parkinsonian tremor. Sometimes dystonia has a null points. In such a case, if its cervical tremor diminishes on turning the head to the left or right, it might more likely dystonic tremor than essential cerebral tremor. You might ask the patient to relax with eyes closed and let the head drift to wherever it feels more comfortable, a maneuver that often leads to unrecognized torticollis or laterocollis. Good to remember that tremor is irregular in dystonia, in contrast to tremor in essential tremor. The next problem is the failure to recognize a second movement disorder that coexists in a patient with dystonia, leading to mislabeling and isolated dystonia to a mixed or combined movement disorder. Such combination are dystonia and tremor or chorea and tremor. Remember, chorea is not a pattern movement disorder, and it produces movements that vary randomly in duration, direction, and amplitude. In chorea, abnormal movement flows. In dystonia, it's an overflows. It means it goes from one segment to the other in a random and unpredictable way. Myoclonic jerks can be mistaken as jerky movement in dystonia. When myoclonus coexists with dystonia, it usually be present not only in the part of body affected by dystonia, but also in non-affected parts. For example, in the myoclonus dystonia syndrome, a hereditary form of combined dystonia, myoclonus is more prominent in the neck than in the arm, and dystonia in the arm than in the neck. Finally, athetosis is actually another form of dystonia. The value of recognizing athetosis is that if misdiagnosed, it can lead to diagnosis combined rather than isolated dystonia. Both of these errors can lead to incorrect syndromic diagnosis and thus inappropriate etiological diagnosis. Detecting pyramidal signs such as spasticity, hyperreflexion, or Babinski sign in dystonia can sometimes be difficult because hyperreflexia can occur in dystonia, presumably due to reinforcement of reflexes from dystonic muscle activation. Plantar responses also can appear extensor due to a striatal toe, mimicking the Babinski response. In a striatal toe that's seen in dystonic disorders, toe remains upwarded for a while after eliciting the plantar reflex, and there are no finger fanning actually. There are a few clinical points in differentiating spasticity from dystonia. First of all, spasticity is velocity dependent. When examining the patient's tone, spasticity increases by the velocity. In contrary, dystonia is not. You can find spasticity at rest. This is not common in dystonia. Dystonia increases by voluntary movement, and you cannot see it at rest. Spasticity is continuously seen throughout the gait, from beginning to the end. However, dystonic posture is variable. The leg dystonic stiffness and posturing can improve significantly or may even be absent during different walking tasks, such as walking backward, walking heel to toe, or running, whereas a spastic gait does not change significantly according to a task. It's essential to find so-called process movement disorder to label it as a combined dystonia. Dystonia can combine with any other movement disorder or neurologic manifestation, such as Parkinsonism, spasticity, myoclonus cerebral ataxia. In infantile or childhood onset dystonia with Parkinsonism, dopa-responsive dystonia are the primary diagnosis to rule out. It could be autosomal dominant due to GCH1 mutation or other recessive ones like TH mutation. The phenotype is usually complicated with varying combination of dystonia, Parkinsonism, pyramidal signs, intellectual delay, or autonomic sleep or endocrine disturbance. However, in adolescent and young adult onset dystonia with Parkinsonism, the most likely diagnosis is one of the genetic forms of early onset Parkinson's disease. Pallidopyramidal syndromes are leading cause of dystonia with spasticity with or without Parkinsonism. Pilopyramidal syndromes are divided into with Parkinsonism or without it. In this case, it's crucial to determine whether spasticity or dystonia is the dominant clinical feature. For example, if spasticity is the dominant feature and the syndrome is familiar, it's more likely as hereditary spastic paraparesis, HSP. But if dystonia is the dominant, a number of multi-system neurodegenerative disease are probable cause. Two questions should be addressed whenever facing dystonia combined with cerebral ataxia. The first is which one, dystonia or ataxia, is the dominant motor phenomenon. If ataxia is dominant, the focus should be on the differential diagnosis of ataxia, such as the spinocerebellar ataxia. However, if dystonia is dominant, then a number of multi-system neurodegenerative disease should be considered. The second major question is whether the condition is genetically determined or a sporadic disease. Well, in the last part of Axis 1, you have to evaluate your patient for other neurological or systemic disorders. Of particular importance are ophthalmologic symptoms or signs, such as Kaiser-Fleischer rings for Wilson disease or supranuclear gaze palsy in PSP or Niemann-Pick or Gaucher disease. Other essential signs or symptoms are cognitive impairments, epilepsy, myelopathy, autonomic dysfunction, neuro or myopathy, or systemic involvements, such as organomegaly. Well, let's go to Axis 2. Dystonia has a diverse differential diagnosis, from sporadic to hereditary. So choosing the right diagnostic tool to prove or disapprove the diagnosis is challenging. In recent years, there have been significant advances in our understanding of etiologic basis of dystonia, supported mainly by discoveries in the imaging and genetic diagnostic techniques. Careful clinical evaluation of patients with distinctive radiologic or genetic characteristics in turn has led to a new way of thinking about growing list of disorders in which dystonia might be isolated or combined with other clinical features. It has been emphasized that currently there are no widely accepted guidelines for choosing which tests to be conducted in which order. A shotgun approach that involves testing for all potential disorders is not suitable for many reasons. First, a huge number of tests are available for dystonia, and some of these tests are very expensive, such as the genetic tests. A few of them are invasive and comfortable, such as skin or bone marrow biopsy. Many dystonic syndromes have diagnostic brain imaging findings. Although brain MRI is not necessary for the most adult onset focal dystonia, it's indicated in all early onset dystonia and also in combined one. Please remember that MRI should include iron-sensitive sequences. Brain CT scan is indicated when looking for basal-ganglial calcifications. Neurodegeneration with brain iron accumulation, or NBAAs, describes a group of non-homogeneous disease defined by a combination of progressive neurologic disorders and MRI findings suggestive of increased iron deposition, often involving but not necessarily limited to globus pallidus. In this picture, you can see the famous tiger eye sign. In Wilson disease, it can be associated with both hyper and hypo-intense lesions on both T1 and T2 whited brain MRI sequences. Routine blood investigations are also relevant in dystonic evaluations. You can choose many of them according to your primary diagnostic. But don't remember, you have to check for Wilson disease in any cases. There are other specific tests, again according to your diagnosis. In the past few years, genetic testing has dramatically changed. The traditional approach to genetic testing using karyotype or Sanger sequencing is increasingly being replaced by newer generation sequencing. These techniques are cheaper and more powerful. Here are the most common form of inherited dystonia. There are growing lists also. Let me give a brief description of some of the most common dystonias. In monogenic isolated dystonia, DYT due to TOR1A or DYT1 is one of the most best known. Its autosomal dominant starts at early childhood and became generalized in a couple of years. The most important clinical feature is that the face and neck are usually spare. This is in contrast to DYT due to mutation in THAP or TAP1 or DYT6, which has the same profile as DYT201 but involves face and neck. DYT-GNAL or DYT hereditary dystonia due to GNAL mutation is a rare but trendy dystonia because it causes in isolated cervical or cranial focal or segmental dystonia. And for monogenic combined dystonia, dopa-responsive dystonia are the most important ones. DRD has many genetic causes. GHC1 and TH are well known, with childhood onset dystonia and Parkinsonism, diurnal fluctuation, and excellent response to dystonia. GCH1 is the AD and TH is autosomal recessive. To sum up, dystonia is not only a tonic but also a phasic movement. Approach to dystonic patient should be started on two axes and do not use shotgun approach. And this is my presentation. Thank you for watching and hope you enjoy it. Have a good time.